Hello, everyone. My name is Anna Rosnowski, and I'm the Chief Operating Officer of CDIQ Consulting. We are thrilled to welcome you to our free comprehensive CDI Apprenticeship webinar series for April 2025, Navigating Your CDI Journey, Chart Review Techniques focusing on renal diseases today. We understand how important it is for you to build a solid CDI foundation, and these live interactive webinars focusing on CDI fundamentals give you a chance to preview the thought process behind meaningful chart review. Now I'm honored to introduce our founder and CEO, Dr. Tarman Aziz, MD, CCDS. Dr. Aziz is a recognized speaker in the HIM industry, presenting at both AHIMA's 2025 Virtual Coding Summit earlier this year and Maryland's ACTIS chapter meeting earlier this month. Dr. Aziz, please take it away.
And thank you so much, Anna, for that introduction. I really appreciate it. And welcome to everybody. It's great to see some familiar names and some new names signing on today for the free webinar series. We are really eager, as Anna said, to share our expertise. I've worked for a number of years now in both CDI operations and revenue cycle consulting, and worked in even the AI software industry as related to the applications of CDI for as a medical director composing a curriculum for education. So we really are about education and empowering others. We're going to be at a number of national conferences moving forward as well, which is very exciting. So you'll see our ads and our announcements for that evolving over time. I'm really particularly passionate about understanding how provider documentation aligns with the right ICD-10 codes and how you might find faulty documentation that prompts the query process. Those who are curious or newer to the CDI profession may want to know how that works. And so today we'll have a chance to apply all of that information to the renal system. And we'll only talk about some diseases: acute kidney injury, chronic kidney disease, and end-stage renal disease today, because we don't have time to comprehensively cover every single kidney disease in the time allotted. But for those who are curious and interested, always feel free to reach out for more information, and we'd be happy to send it to you. Of course, we do have a wonderful team, as you see on this shared slide at the moment. And thanks to Anna and the rest of the team, we operate a very efficient and productive organization. So today, quite specifically, we'll be focusing on common renal conditions, as mentioned, and the key clinical indicators in the record that can help you to identify that which you may need to ask questions about. We'll particularly focus on those three conditions I mentioned, and we'll try to understand the best practices for validating certain renal diagnoses. Validating a condition means that you look at the risk factors, the clinical indicators, and the treatments that support coding the condition. And to do that, you really have to dig into the assessment and plan portion of the provider's notes to fully understand what's going on. So precise, thorough clinical documentation is the goal, and your provider queries most of the time are the way to get that accomplished. It's not enough, as mentioned in previous sessions, for providers to respond to your queries on the various forms, but they must also change their ongoing progress notes all the way through to the discharge summary, such that it's in alignment with the query response. Otherwise, they can set up a potential conflict on the medical record. So more about conflicting documentation in other sessions, and to a degree in this one as well. So as mentioned, we'll be looking at AKI, CKD, and end-stage renal disease in this current discussion. Let's begin with acute kidney injury, which of course may be unspecified with the N17.9 ICD-10-CM code, or it may be with various additional features that make it more specific. And one of those, of course, is AKI with acute tubular necrosis, which comes up a lot more often than other types of necrosis within the kidney. And so we won't focus on all of those other subtypes today, but at least we'll give a shout out to ATN along with AKI. So in the industry, we follow various criteria, and years ago, we had other criteria for acute kidney injury. Some of you may remember them, like the rifle criteria, for example, was an older one, and also the AKIN, AKIN, AKIN criteria. But nowadays, the Consortium Kidney Diseases Improving Global Outcomes, or KDIGO, put out in 2012 and then had some revisions subsequently, the best followed, most widely followed and used criteria in the uh, assessment of acute kidney injury. And it focuses on a number of potential factors that we'll look at next. In part, it revolves around serum creatinine trends, or it may revolve around urinary output. So we'll come back to that. AKI um, is really acute kidney failure or acute renal failure, but we use this term acute kidney injury quite often clinically. If you look it up in the code books, it's acute renal failure rather than acute kidney injury. So the point is that the words kidney and renal are interchangeable, and the words injury and failure are interchangeable, and any combination thereof will be fine if the provider properly assesses a clinically valid case of AKI and uses that language. You wouldn't need to send them any query. The problem comes about with the second bullet point that's listed there, less appropriate descriptions of acute kidney injury that do require query so that you can capture the right ICD-10 code. And some of those you may have read providers' charts in the past, and you're familiar with the notion of them writing. For example, they may not write azotemia. Most providers are good about distinguishing azotemia from AKI, but they may write acute renal insufficiency or acute kidney insufficiency. I'm old enough that when I was trained as a physician, many of us use the word insufficiency to imply a failure. And some of the physicians still do that to this day. But really, renal insufficiency is not true failure. And when you use terms like insufficiency, they don't line up with the criteria to code acute kidney injury. AKI is such a commonly encountered condition. You see it often with pneumonia admissions. You may encounter it often with other types of admissions as well, but it's very commonly encountered with patients who are severely dehydrated, or those who are exposed to nephrotoxins, perhaps in the background of a chronic kidney disease, where the threshold for AKI is a little bit lower. So not, but any of those words may trigger your concern if you see that acute kidney injury seems evident from the record, and yet they're using these less appropriate descriptions in the provider notes for documentation. Oliguria is a feature of AKI. It's one of the criteria to have a low urine output, but it certainly doesn't substitute, nor is it a synonym for true acute renal failure. And the last two statements there, renal failure and kidney failure, lack the acuity. So we don't know when a provider writes renal failure or kidney failure, even if the setting clearly suggests that this is happening in an acute timeline. Uh, it's not enough just to write those. You wouldn't know what to code from renal failure and kidney failure in the first instance. You'd have to really think about the other circumstances. But either way, you're not going to have the right code. And that means you're not going to have a couple of things on the record that are very important. Number one, AKI is a qualifying comorbidity condition or CC diagnosis. So it means it has the ability to shift the DRG assignment, the MS or Medicare severity diagnosis related group assignments are contingent upon how many CCs and MCCs, major comorbid conditions, are present on the record as secondary diagnoses. And certainly AKI is also an important reason for admission and may serve as the principal diagnosis. But most of the time, when you're reviewing charts in the CDI world, AKI and the need to query for it is contingent upon its presence as a secondary diagnosis that is not being picked up in the coding, final billing of the case, and therefore suboptimal DRG may result, Also, suboptimal severity of illness and risk of mortality calculations using the APR DRGs for SOI and ROM on the groupers. So very important condition to remember. And the associated condition, acute tubular necrosis, if that's the type of AKI present, is an MCC and has even greater fiscal impact. So besides revenue, why else might we care? How about risk adjustment? AKI and particularly AKI with ATN, but also unspecified acute kidney injury, is a major cause of reasons for prolonged hospital stays. So your expected length of stay can change as a result of the presence of these conditions. If the condition is not documented properly, how would we ever capture that so-called risk-adjusted impact to length of stay? And of course, we have other risk adjustment issues like readmission risk, 30-day readmission risk for the inpatient setting, as well as expected mortality, which is super important for some service lines like cardiothoracic surgery, where so many major cardiothoracic surgical procedures are procedures where temporarily the kidney is denied proper flow of blood, then accordingly we can have AKI results. If it's not captured with the right descriptions, it's never captured as a true ICD-10 code that aligns with the patient's level of illness, and it reflects across all those metrics. So what I've just mentioned applies to so many conditions, and most importantly, today we're talking about how it works for AKI and ATN in this slide. So if you've met the clinical criteria upon looking at the chart and you don't see AKI, we expect to see it there in some way and not as an abbreviation in the first instance. Hopefully, the very first time a provider mentions acute kidney injury or acute renal failure or any acceptable terminology like that, you'd want them to spell out the condition in its entirety the first time. If they write acute renal failure and they don't spell it out and they send just write ARF, and the patient happens to have respiratory failure as well, you can see how ARF, the R, is it renal or respiratory? We don't know what it stands for. So very important to clarify that. The clinical criteria validating AKI, this is another story where perhaps you may have AKI well documented. Acute kidney injury is suspected all over the record, but you're not quite seeing the clinical criteria to support it. Then again, you may send another type of communication where you query the provider and say, okay, we see you've assessed AKI. Can you share with us additional validating entries or additional validating evidence of the condition? This is one of the biggest difficulties for new CDI specialists to overcome, the confidence to so-called question a provider's diagnosis. Of course, you're not doing that at all. If you write up the query in a compliant way, consistent with AHIMA guidelines, then you would realize very quickly you can ask the question without leading the provider one way or the other with an opinion, simply saying, please provide additional indicators supporting your diagnosis. Now, reading between the lines, the provider will realize that you don't think there's enough indicators on the record. That doesn't necessarily mean that the provider doesn't have an insight that they can add to validate the condition that would have otherwise not been documented. So make sure you ask the question both ways. If you think acute kidney injury is there, not being documented, get it on the record by query. If it's being documented and it really didn't manifest as true acute kidney failure, and they keep diagnosing the condition, you may have to send a clinical validation query to see if the record should really reflect that condition or not. Either way, it's your right as a CDI specialist to ask, as long as you have all the ingredients. So most queries to establish AKI will require this three-pronged approach. You need to give providers in the top of your query form the apparent risk factors that you feel were evident for the condition, as well as all the clinical indicators and the treatments that apply to the case that you were reviewing. So I'd love to turn the discussion over to the group To consider the questions that are in bold and italic font there, maybe we can start with the apparent risk factors. What are some typical risk factors for developing acute kidney injury or acute kidney injury with ATN? Either one.
A CAT scan with contrast.
Very good. A CAT scan with contrast can, for some people, trigger a nephrotoxic reaction that can lead to acute kidney injury up to and including ATN.
Trauma.
Long
I heard somebody say trauma. That's accurate. Very good. Trauma with
diuretics.
good diuretics. What do diuretics and trauma have in common? We're losing a lot of fluid, potentially, right? How much of the blood supply does the kidney get with each pump of the heart? What percentage of the cardiac output is recruited? It's around 20%. Some books will tell you 25% of the cardiac output with each cycle goes out to the kidneys. So if you're denying that fluid in the form of trauma, perhaps hypovolemic trauma with severe bleeding, or in cases of excess diuretic use, the kidney may not be happy about that, and you can see some AKI. Very good. There are other nephrotoxins. What antibiotics put us at risk of acute kidney injury? What would you say the leading one would be?
Vancomycin.
Very good. Vancomycin, so commonly utilized. Very good job, Karen. Vancomycin is commonly used because of life-threatening gram-positive infections. So we get where the provider is coming from in ordering the vancomycin. And especially if the patient already has chronic kidney disease, they can develop acute kidney injury superimposed on the chronic kidney disease because of vancomycin use. And you will see that those providers will promptly discontinue vancomycin and switch to another class of antibiotic that maybe will be a bit more gentle to the kidney. And yet they won't actually explicitly mention acute kidney injury, even though the evidence is there. They may use other euphemisms that are not even on this list. A common one I see out there in the industry is creatinine bump due to vanco, or creatinine spike due to vanco. We get what you're saying, providers, but creatinine bump or creatinine spike is not the same as acute kidney injury. They know it, we know it, and they just shouldn't write that. But many of them do. Some of them are not doing it facetiously. They just genuinely think that's enough to indicate acute kidney injury to CDI specialists and coders. And the reality is, as clinical as some of us may be in our backgrounds, CDI is a non-clinical role. So we're not allowed to translate jargon and say they probably mean acute kidney injury. Let's pick it up and code it. So that's the problem at hand there. Very good job. Thank you for the participation on those. What about the indicators? What might you expect to see to truly call it acute kidney injury, not just a little bit of free renal azotemia?
Edema in legs and feet.
I'm sorry, go ahead, please.
Edema in legs and feet and decreased urine output.
Very good. Yes. Peripheral edema, particularly in the lower extremities. Nicely said. Yes.
Creatinine blood ratio.
Elevated blood urea nitrogen, creatinine.
Yes, good. Elevated creatinine. How much must the creatinine be elevated over the patient's baseline to be considered acute kidney injury?
0.3 milligram per deciliter within 48 hours.
Very good. If somebody is developing AKI within the hospital setting, perhaps like the vancomycin example that was given, you would need to see at least a 0.3 milligram per deciliter jump in a 48-hour window to consider acute kidney injury. How about if the person arrived to the hospital with acute kidney injury, and at the end of the case, you notice that the creatinine is normalizing back towards the patient's baseline? How high must the creatinine have been in that case retrospectively viewing to establish POA or present on admission AKI? Does anybody know?
It's 1.5 times the lowest recorded creatinine within the last 7 days.
Perfect. Very nicely stated. Thank you. 1.5 times baseline in hindsight within 7 days. So you may not know the patient's baseline. What should you do if you don't know the patient's baseline serum creatinine? How will you decide what to call the baseline creatinine when you're doing these calculations?
Blood levels in the ER or when they're admitted, and then trend them every day.
Okay, I like your answer, Alicia, for when AKI is developing during an admission, for sure. What about if the patient comes in and let's say their creatinine is 1.6 and it drops and drops and drops and the patient leaves with a creatinine of 0.9. Do you use that final value or do you use another value for the baseline? Which value might you use for the baseline in that setting? So if you don't know, it's the lowest serum creatinine encountered during the admission that can be used as a substitute for the baseline serum creatinine. Remember, in my example, patient went from, say, 1.5 or 1.6 on admission serum creatinine down to 0.9. But what if they had a 0.8 or a 0.7 somewhere along the line? Even though that may not be the best value, we're allowed to use that lowest value in the set for the admission as the presumed baseline value. There would be some margin of error around that practice, but the KDIGO criteria allow for that. So very good answers, very good input from all of you. How about treatments? What are the typical treatments you might see for AKI?
Treatment of underlying cause.
Very good. Treatment of the underlying cause. Some patients have a critical renal artery stenosis for which they may need stenting. And when you relieve the stenosis in the renal artery branches, now the kidney can receive blood adequately and you've addressed the AKI. You may also treat the underlying cause in the way I described, remove the nephrotoxin. Right? If you've got a known nephrotoxin, stop using that nephrotoxin. It doesn't have to just be extreme examples like vancomycin. Abusing non-steroidal anti-inflammatories can also invoke AKI with or without ATN. Commonly, it has ATN mixed in there with NSAID abuse. What else? What are you going to see in terms of administration of fluids, for example, with AKI?
Normal saline.
Probably normal, half normal saline. What about the rate?
Increase volume.
Bolus.
Sorry, I heard increase, which sounds right.
Increase volume of IV fluids.
Yeah, you might increase the volume of IV fluids, the rate of IV fluids. It's not uncommon to see if you research on the electronic medical record, oh, they started the IV fluids at 75 or 80 mils per hour, and suddenly they bumped it up to 125. Why is that? Oh, look at the serum creatinine rising. So we can think possibly that could be a treatment for AKI as well. You can also use in the CDI world serial measurements of lab values more frequently than normal. Think about an earlier session we had in this webinar series where we discussed acute blood loss anemia. And one of the ways in which you can show that acute blood loss anemia was being treated is by showing serial hemoglobin values, multiple hemoglobin readings, for example, in one day. So same goes for excessive screening for the serum creatinine, additional serum creatinine values through additional chemistries. You can also substitute as a treatment for AKI, not only the fluid rate.
And if a patient has a history of CHF, then what we will do with the patient with acute renal failure, because we cannot increase IV fluids in CHF patients.
Yeah, that becomes a very delicate balance. You'll see a number of different treatments invoked depending if the patient has pure left-sided heart failure or also combined left and right-sided heart failure. And there may be the need to use other agents pharmacologically to monitor that. So that's a complicated management. In CHF, we definitely need to be careful with not pushing IV fluids too quickly then to exacerbate pulmonary edema, for example. So you raise another good point. Fantastic. Okay, what if there's a conflict about AKI? What if the attending physician feels that there's AKI? You look at the lab values and you agree, or the interventions and you agree, but there's a consulting nephrologist on the case, and the nephrologist doesn't think that there's AKI. Then how can you handle such a case? What would you assign the condition AKI? Would you go ahead and code it despite the nephrologist not mentioning it? Does it matter if specialists disagree with the admitting provider?
I thought they had to give their feedback to the attending, and then the attending does the diagnosis. I'm not for sure.
You're absolutely right. The way it's meant to work is that way. Karen, did you have a thought as well on that? I saw your microphone.
I was saying I probably sent out a conflicting query for conflicting diagnosis and go with their attending because he's the driver.
Very good. So you might need to send a conflicting documentation query to the attending physician to say, look, you've consulted a nephrologist. They've gone ahead and written a note, and they've even said, we doubt AKI is present. And yet you continue to write acute kidney injury. So you may want to query the attending provider to just chime in on that discrepancy. And is it that they just didn't read the note, or did they read it and not agree? A good rule of thumb is for providers to say in their discharge summaries or close to the end of the case in one of their progress notes, such and such diagnosis, and then add in there nephrology input noted and appreciated. We're still going with AKI, right? It's okay. The attending physician has the final say, as was correctly stated. Sometimes the nephrologist doesn't write anything about AKI. They don't say anything one way or the other. It's uncommon, but if they don't say much of anything, you don't need to send a conflicting documentation query necessarily. You wouldn't say, well, you've mentioned AKI, but they've said nothing. The fact they've not said anything at all one way or the other means it's less important because, as mentioned by Karen correctly just now, it's the attending say-so, the admitting physician has the final word. So there's a lot to think about here. Let's move on and look at those KDIGO criteria then. We've already talked about them by way of your excellent contributions. You can have any of these three sub-bullets present to pick up AKI. Serum creatinine increased to greater than 1.5 times baseline within 7 days, as was correctly mentioned. Or you could have the 0.3 milligram per deciliter within 48 hours over the course of the admission, or you could have all by itself urine output less than 0.5 milliliters per kg per hour for at least 6 to 12 hours. That will also be a good way to assess. So the vital signs are vital, the flow chart and the flow sheets are vital. You must definitely look further than just assessment and plan when thinking about this diagnosis. And baseline creatinine could be established from values up to a year ago. That's a big deal because in general, in CDI, we say the loose rule of thumb, don't use any old information, use only information from the current admission to formulate your query. And here we are now saying here's an exception to that rule. When you're trying to figure out the baseline creatinine, consider setting your EMR back 1 year in time and see if that patient has other serum creatinine values in the health system already because they've been seen in the outpatient setting or maybe in other inpatient admission. See if you can get the baseline estimated from that. You may find it in old provider notes as well, up to a year earlier. But if the baseline's unknown, as mentioned, use the lowest available serum creatinine. Where most people go wrong is they think all three or two of the three have to be present to pick up acute kidney injury, and it's only one, any one of those three is sufficient for the diagnosis. ATN, of course, is an extension of AKI. It's a more specific form, acute renal failure with tubular necrosis. And here we really see more dysfunction and some damage than we see true death of the tubules. What we need first and foremost for ATN is for the KDIGO criteria for AKI of any subtype to be met. So first, fulfill KDIGO criteria. And then secondarily, the serum creatinine elevation must be there no less than 72 hours, despite adequate fluid resuscitation efforts. Those two both must be present for ATN to be assessed. And the other items listed with the square bullets here, fractional excretion of sodium greater than 2%, muddy brown casts, and biopsy evidence of ATN must not necessarily be present. Those are confirmatory factors. But we know, for example, Saira mentioned a good point about CHF earlier. Patients with advanced CHF, patients with cirrhosis, they may not have a FeNA greater than 2%, yet they still have ATN. You may not have seen enough epithelial cell death and sloughing to have true muddy brown casts, and only about 10% of patients actually even get biopsies. And the biopsy may miss an area of necrosis. So providers, I mentioned those 3 bullet points because this is how they oftentimes push back. When you send a query for AKI with ATN, there can be a pushback that states, hey, you know, there's no biopsy. Don't ask me that. I don't know if it's ATN without a biopsy. That is completely unnecessary to make this diagnosis. Now, of course, the provider has the right to their independent medical judgment, but they may not know that they can pick up suspected, probable, or likely ATN in their language, and they would then still endorse the coding of the condition. So if they truly think this is a likely suspected or probable case of ATN, that's a way for them to document the condition without committing to it so definitively, and it will still allow for that risk adjustment and revenue impact to be picked up. We're not meant to force providers to do that, but we're also not meant to accept flimsy excuses because providers know all too well that the FeNA doesn't always exceed 2% and that the casts are not always there and biopsies are not commonly done. So when you query around these processes, don't let providers bully you into thinking that your query was in some way insufficient, because most likely it's their thinking process that's insufficient rather than your query process. They're simply mentally shut down to the process of CDI and see it as a big nuisance. And so your job is to sort of tease them out of that position. It may be easier to invoke the risk adjustment items like readmission, length of stay, and mortality than money. Providers get quite sarcastic about facility fee billing because they're more concerned about their own professional fee than the facility fee. But there's ways to get to their hearts and to get them to understand the value of all of this. Just like the last slide, contrast-induced nephropathy doesn't work for AKI. Neither does tubular necrosis. If you don't mention the acuity, you need to say acute tubular necrosis. And if it's ATN, acute kidney injury all by itself is not a substitute for ATN. You have to say ATN or AKI with ATN in your assessments and plans to pick up that N17.0 code for the condition. Again, ATN is an MCC, so look out for those prolonged serum creatinines or very markedly diminished urine outputs. All right. Any questions from the group on this before we move off of this and on to CKD, chronic kidney disease? If not, we can move on then to CKD. So chronic kidney disease. Some types of chronic kidney disease are CCs. comorbidity diagnoses that impact the record. Does anybody happen to know, looking at the stages below on the bottom of the slide, which stages of CKD serve as CCs on an inpatient medical record?
CKD 4 and 5.
Very good. Thank you, Miasol. CKD 4 and 5 are the types of CKD stage which can get you a CC. For that, you'd need to see an eGFR lower than 30 for stage 4 and below 15 for stage 5. How about end-stage renal disease? Does it have an impact on the metrics of the record?
It's a MCC.
Very good, Saira. It's a MCC, major comorbidity and complication, which has dramatic impact on the record, both from a risk adjustment standpoint. It's very important to mention that in the next version of risk adjustment, ATN, our last condition, has been removed, as has AKI, as a risk adjustment diagnosis. And the reason is it's felt to be a transient, those are felt to be transient diagnoses. And if they're significant, they'll likely lead to the use of dialysis and potentially end-stage renal disease. So for chronic risk adjustment, it's the end-stage renal disease that's used now more commonly than acute kidney diseases moving forward with V28. But getting back to the KDIGO guidelines, we also have them for CKD. We want to see at least for 3 months or longer one of the following: the GFR less than 60 and or lab data or biopsy findings that would suggest kidney damage. Remember, we have a pretty reasonable renal reserve, and we don't really get symptomatic until we're at CKD stage 2 and onwards. That's why many labs have above 90 or below 90 as our reference range. Some even say above and below 60, depending on the lab, but most of them will start measuring at 90. You can see that the stages are listed here. You should have a working knowledge of the GFR ranges and which stage of chronic kidney disease it aligns with. Most importantly, stage 3A and stage 3B are more recent staging. They're not so recent, but they're more recent than to the point that many providers don't bother to specify 3A and 3B. If the GFR falls between 30 and 59, they'll still just write stage 3. It should be mentioned that stage 3, whether it's specified or not, as well as 3A, 3B, 4 or 5, and ESRD, all have hierarchical condition category or HCC value, meaning that they will impact both inpatient risk adjustment as well as outpatient risk adjustment factor. So CKD is a very important diagnosis. It's commonly present on the record, but just as common as that, it's common not to stage it. So many times CDI specialists will send multiple CKD staging queries in a given month, particularly when it's at the 3A or higher stage to capture that comorbidity impact. It's really important that you notice this word down here as well. End-stage renal disease requires a low GFR below 15 and chronic dialysis dependence. Meaning what? It means that sometimes we give dialysis in the hospital setting, and that's it. The patient doesn't need Monday, Wednesday, Friday outpatient dialysis. So the words dialysis dependence don't work as a substitute for ESRD, as we'll see in a moment. End-stage renal disease implies permanent need for dialysis, not just 1 or 2 rounds of dialysis in-house. So it's an important distinction to make. Again, providers like to use euphemisms for actual diagnoses. So low baseline GFR, not good enough for CKD, or high baseline creatinine, either of those will fail to capture any codes for CKD at any stage. Chronic renal or kidney insufficiency, some would say you can code from that. I think there's a technicality that allows you to, but it's not well advised. Really, chronic kidney disease is ideal language, and you want to give the stage. If there's no stage, you're not likely to capture the appropriate metrics. And also chronic uremia. We can appreciate clinically what the symptomatology of uremia represents, but we don't necessarily want to code CKD from chronic uremia. That's a very old-fashioned way of writing out the condition, and it really implies more than just CKD is ongoing. Finally, ESRD. Again, we want to link that stage 5 CKD level GFR with a dialysis dependence, but the key word here is chronic. Chronic dialysis dependence, meaning multiple times weekly as an outpatient, and the GFR is less than 15. Those two both need to be present. So watch out for provider assessments that say things like CKD5 on hemodialysis. That's not a euphemism or an equivalency term or a synonym for ESRD. Only end-stage renal disease really captures the illness from a risk adjustment and MCC standpoint for DRG assignment. So I don't know if on hemodialysis means the inpatient dialysis that may be ongoing, or it means that the patient needs it all the time. So that's very important. Also, document any renal transplant history. That's important for picking up the Z codes for renal transplantation history, but the fact that a person required a renal transplant is not letting us know about a current episode of ESRD. And remember, people who have renal transplants can develop CKD in the transplanted kidney. It should be documented post-transplantation with the appropriate stage, and they may even proceed to end-stage renal disease even after the kidney transplant, because the same provoking factors that cause the renal failure are still there. And again, remember the term dialysis dependence does not delineate between acute inpatient dependence and chronic dialysis requirements. So that's the hardest thing to get providers to do. And it's even harder when the patient has had CKD stage 5 for a long time and nobody's bothered to update the stage. Sometimes they have CKD stage 5 with a GFR less than 15, and you look at the problem list or the subjective narrative, and it's still saying CKD stage 2 or 3, regardless of the evolution of the condition. So you want to make sure the right stage is there, and if there's dialysis required, make sure you delineate between temporary and permanent. Okay, so chronic dialysis dependence is critical to the condition. The final thing to mention is end-stage renal disease comes with so many other comorbidities as a result of the illness, and yet we don't always see providers separating them out. So the hyperkalemia, metabolic acidosis, and secondary hyperparathyroidism, those types of conditions that exist with ESRD, oftentimes they can present with ESRD. ESRD doesn't impact all of that comorbidity value into the patient's chart. Each and every one of those needs to be listed separately and yet still linked back to ESRD if that's a suspected cause. Remember, ESRD is generally not a reason for admission to the hospital. So most of the time when patients are admitted who already have end-stage renal disease, it's a secondary MCC, and the primary or principal diagnosis, PDX, is likely to be one of these 4 items listed here. Secondary hyperparathyroidism may well be an additional comorbidity, and it's important to capture because it too is a CC diagnosis, carries its own additional comorbid impact. So to finish up, I've got a few practice questions for us to look at. I will leave it for each of you in the group to read the question, and if anybody wants to take the microphone and share what they think the answer is and why, most welcome to do so. Others may want to share in the chat box if they prefer not to speak, but I'd love to hear from any of you on this set of questions. I'll remain silent so you can read them. Okay, we discussed this scenario just a few slides ago. Does anybody want to hazard a guess to this one?
Is it a C?
Very good.
I also agree. C.
Very good. Acute kidney injury with suspected, there's that suspected tubular necrosis given the non-responsiveness to IV fluids. This is ideal documentation. It identifies a subtype of AKI, unlike choice B, which just would lead to AKI unspecified, ACC, where we clearly have indicators for ATN. We have the provoking risk factor, we have the sustained creatinine elevation still on hospital day 4, it's still high, regardless of good fluid volumes being delivered. So we don't want B and D because those are unspecified AKIs. A uses the term insufficiency, and concern for, even though they've said concern for is not a modifying term that allows you to code a condition. We can use suspected, probable, likely, compatible with, consistent with, possible. Those are all terms we can use, but not concern for. That doesn't code to anything specific. So good job on that. Let's take a look at the next one, please. So there's a lot of information in this question. What do you really need to know to answer it, though? Not much. Once you read through the question itself, what do you need to get this one correct? A working
B.
understanding of what? Very good. You're correct. B is right, Saira. Can you tell us why you chose it?
The GFR rate is 31.
Exactly. It's as simple as knowing the correct association between GFR and stage.
Type 2 diabetes also mentioned in history.
Exactly. Can you imagine that many people will choose choice C incorrectly because the history mentions both hypertension and diabetes, and yet choice B only mentions diabetes? Perhaps the provider had some insight into diabetes being more plausible etiology for the CKD. So you wouldn't want to pick the wrong stage just because both potential etiologies were not mentioned. We see that sometimes when we give this practice question in our courses. Chronic renal disease has no stage in choice A, and choice D, staging requires outpatient workup. Absolutely not. You can stage it right there as an inpatient. Nice to confirm it with outpatient workup, but not necessary. Very good. Thank you. Next one, please. Keep in mind that dialysis dependence is not synonymous with ESRD, end-stage renal disease. We see that the GFR here is 10, so it's below 15. And we also see that the patient missed 2 outpatient dialysis sessions, which reinforces the notion of end-stage renal disease. rather than just CKD stage 5. So we've got an end-stage renal disease likely here. And we know that the terms requiring hemodialysis or with dialysis dependence don't necessarily work because we don't know if that's in-house or not. So very good. Alicia, I agree with you. C is the best answer here. The reason for admission would be hyperkalemia in the setting of end-stage renal disease for the best documentation here. While choice D, CKD with dialysis dependence, sounds okay, you'd have to have read the subjective narrative portion of any notes to appreciate that we're referring to constant, permanent outpatient dialysis setting for choices D, A, and even B. They all fail to clarify true end-stage renal disease. So it's a little bit of a subtle point. Providers don't like it when you push this concept, but only end-stage renal disease in this instance compared to the other three choices would capture the condition accurately. That means capturing it for revenue and risk adjustment purposes. Good. Okay, next question. So here we have a 68-year-old man, stage 4 CKD, fatigue, muscle cramps, confused, calcium is low, phosphate is high, GFR is below 30. And we want to query in this case because documentation fails to identify a common comorbid condition that's in this clinical picture due to which of the following. So here we're testing the knowledge of the medical condition, which sometimes also comes up with CDI training and CDI certifications. You need to know some medical facts as well to make it through. So who can pick the right association here?
C. No.
Sorry, I lost your connection a little bit.
It's C. No,
In this
sorry,
case,
I'm wrong.
no, you're okay. In this case, it would be secondary hyperparathyroidism. Remember that primary hyperparathyroidism, you would have a high PTH and therefore a low phosphate. And the mechanism with CKD4 is insufficient vitamin D activation, and or they could have also mentioned that the parathyroid hormone doesn't work properly at the distal convoluted tubule of the nephron. Either way, we have dysregulated calcium homeostasis, so the calcium will be chronically low in CKD, and it will cause the parathyroid output to be high as a result. Secondary hyperparathyroidism rather than primary. Excess calcium excretion by the kidneys is just not the mechanism by which this is happening. And increased calcium absorption from the lumen of the duodenum to the intestinal arteries. No, it's decreased because of the failure to activate vitamin D. So hyperparathyroidism is involved. Remember, parathyroid hormone for the primary condition will drop the phosphate level. That's how you know you're probably dealing with CKD4. Okay, one more question, please. And again, to help move the question along, I'll just summarize it. End-stage renal patient, 62-year-old man, short of breath, fatigued, confused. with a rapid deep breathing pattern, respiratory rate of 30 per minute, heart rate of 108, low blood pressure at 90/56. pH is markedly diminished, right, at 7.17. The bicarb is being consumed down to 12. PaCO2 is 28. Very good. I already see the right answer coming in. While we may think of both hyperkalemia and metabolic acidosis here as contenders for the PDX, which principal diagnosis is best endorsed here? Metabolic acidosis. Why is that, from anyone that liked choice C?
From the pH and the confusion, all the symptoms that he's having, and the pH level.
Yeah, the pH derangement is greater, isn't it, than the potassium derangement? And there's a little bit more effort thrown towards regulating the metabolic acidosis. You even see bicarb being added into the IV fluids as a kind of additional. Very good. I really am impressed with everybody's participation and definitely appreciate that participation this evening. As we wrap up here, I'd like to mention that we do have some upcoming free webinars, and we're especially excited to announce 2 brand new free webinar series events for our CDI community coming up next month in May, just in a few days. We're at the beginning of the next month. So we will be, as of the 5th, Monday the 5th of May coming up, releasing our CDIP exam prep product for those that prefer the CDIP route to the CCDS. And our first series premiere topic on May 6th will be applying ICD-10, CM, and PCS guidelines in the context of the CDIP test. Those who are interested in a role in revenue cycle consulting out of their CDI careers, or those who are just generally interested in rev cycle consulting, regardless of their CDI backgrounds, may enjoy our free monthly webinar series that's launching May 13th, where we'll talk about the Inpatient CDI dashboard and ensuring the accuracy of financial impact reporting. And finally, those who are already familiar with our CCDS exam prep free monthly webinar series, on May 20th at 7 p.m. Eastern, we will have a session on evaluating provider assessments for neurological diseases with questions, much in the same format as we just saw. We also have a number of our courses coming up. The live online CCDS exam prep courses begin May 5th and May 19th on the dates and times listed. We have a live online Lunch and Learn comprehensive CDI apprenticeship program that is 40 hours, along with diagnostics, mock exams, practice interviews. Recommendation letters are offered to help get you into the industry if you're new. We have an on-demand CCDS exam prep course available anytime. And we also have coming soon, as mentioned, the CDIP exam prep course that will also be an on-demand self-paced format. For all of our products, we have payment plans available through the third parties that you see listed in the bottom right of the screen. So you need not worry about paying the tuition for the courses all at one time. You can spread out the payments over several months. In the few minutes I have left, I'd welcome any of your questions before I move on to my next meeting for the evening. And thank you again in advance for all of your
Hey, I was
participation.
just wondering if any of the classes have any CEUs attached to them.
We're in the process of applying for the CEUs, but not at this time.
Okay.
Good question. Thank you for asking. We hope that will change very soon. Other questions I might answer from the group before we conclude for tonight? Great session. Appreciated the attendance and participation, for sure.
Thank you, everybody. We do appreciate your time.
Yeah, thank you so much for this opportunity to listen.
Thank you all so much again. Really great to hear from all of you today. Take care,
Thanks.
everybody.
Bye-bye.
See you next time. Bye-bye.
Bye-bye.